कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. Welcome to the next edition of the To S Obstetrics Masterclass Series. I'm Dr. Rohan Palshetkar, and this program has been convened by Dr. Jaideep Tang sir and the co-convener Dr. Parikshit Tang sir. And the program moderators are Priyankur, Apurva, Niharika, and myself. Of over 4,500 people and an average life attendance of 4,200. Today's masterclass is going to be an amazing masterclass with our chief guest for today, Dr. Hema Divakar ma'am. Dr. Hema Divakar ma'am needs actually no introduction. We already know her and she's so well known all over the country. But just as a formality, ma'am, I would like to introduce you in a few words. She's the medical director of Divakar's Specialty Hospital. She's a senior consultant obstetrician and gynac, a past president of FOXY, a vice chair for FIGO PNCD Committee 2015 till date, and the ambassador for the International Organization for OBGYNs FIGO 2016 to 2018. Ma'am, can I please request you to please say a few words for our program, ma'am?
Namaskar. Thank you, Rohan. Whenever you ask somebody, how do you pronounce TNK? So, as in tank, think tank, So, that is what Jaideep Tang, as we call him, Parikshit Tang, are the think tanks of our great organization. And I really, really admire the thought process behind the convening the series of dialogues and programs Wednesday after Wednesday. And as I had a sneak peek at the conversations before we began, how much people look forward to this. And one single most point of appreciation is how the Tanks have nurtured the generation next in having the moderators as our youth leaders from right across the country, which deserves a very special mention. Well, when you say a few words, it is captioned as forward-looking message. Yes, everybody knows that my very favorite caption nowadays has been looking back, moving forward, because we need to sometimes look back to learn our lessons to see what have we not done before, and we have the second best chance here and now to do something forward. But the movement of packed initiatives, however slowly, we have to move forward one step at a time. So we are indeed looking forward to the deliberations this Wednesday too, like many other Wednesdays before and many other Wednesdays to come in future. The deliberation by none other than our very favorite Dr. Jaideep Tang. He is going to speak on fetal growth restriction. But believe me, his thought process and unconditional passion for disseminating knowledge is unrestricted. There is no restriction there, because I have always seen him apply his mind so thoroughly to the presentation that he makes. And it's really into what he wants to convey to the listeners who will have their thought process provoked and who will think what they should change in their practice. And that, to my mind, is a very crucial factor in Jaideep's deliberations, no matter whichever topic it is. And Abha, the other speaker today, again, a forward looking thought process, because fetal growth restriction, in any case, we as clinicians are bothered so much about genetic causes, infections, this, that. Seldom we think about nutrition as one of the underlying causes which can so easily be corrected, and also the developmental implications that it has. And so we are much looking forward to Abhaji's deliberation on that topic. And last of all, the panel, the power packed panel on some simple things. Dr. Mitra Saxena, I must place on records that she is so keen and so passionate, and it's so well deserved that she's stepping into the chairperson of the Practical Obstetrics Committee, because she's really practical in her thought process, very pragmatic, and she attended the Manyata training program to understand what this is all about, and very well recognized that simple things like active management of third stage of labor, simple things like delayed cord clamp, not happening. And nobody can answer why. It's just a presumption that, okay, these things are taken for granted, but not really. She applied her mind, she gathered and galvanized the teams from Haryana to join the program of Manyata, and wanting to really percolate and disseminate, as in the panel that she would conduct today, to look forward for what better we can do. Because if these simple things, which were evidence based and known to us from times immemorial, we should have sorted this problem yesterday. But as I have always believed, a die-hard optimist like myself, because there's no use being anything else, we need to move forward. And this is my forward-looking message, that no matter you look back to learn your lessons, but you move forward with the solutions. And may I wish this entire team the concept behind this to make a real change in the doable and feasible initiatives in practice to change the entire healthcare ecosystem and the mindset of the clinicians and the frontline healthcare providers for a better tomorrow. So once again, the Hey Ma blessings always stays with the entire community of Foxians and beyond. And whenever, whatever is expected of us, we will always be there to do our best. Namaskar.
Thank you very much, Madam, for those extremely kind and generous words, and also for the wonderful forward-looking statement. As you said, we did look quite forward after looking into the past with your statement. So thank you very much. I think Dr. Hema Divakar should probably be renamed as the project lady of Foxy. Her ability to conceptualize, think, execute, roll out, and implement projects really is unparalleled in Foxy. And I really admire her for that. A lot of the Foxy's best work in the past few years actually has come about because of Dr. Hema Divakar's vision, hard work, and dedication. And Madam, I'm sure we are all very, very grateful to you. Thank you for
Jaideep, it's a whole team which always supports, and at times I
yes,
feel
madam.
guilty for making them all, really
All-
thankful to all the champions and leaders. Thank you.
Thank you, madam. Thank you. Rohan, could you take it forward, please? Thank you.
Thank you. Thank you so much, Hema ma'am. Those are some wonderful words which you said, and I completely agree with you wholeheartedly that Jaideep Dancer is always helping us, young brigade, to move ahead, always guiding us and teaching us how to move ahead, how to do these things, and always being there whenever we need him. Okay, so without taking too much time, we're going to move on to our next talk, which is by Dr. Jaideep Dancer. Could I please have his CV, Saurabh? Of course, again, Dr. Jaideep Dancer, there's what else can you say about him that we don't know? He's the Secretary General of Foxy. He's been the past president of MOGS. He's the co-founder of the Esperanza Healthcare Limited program and the member of board for Profert IVF. But one thing I want to tell you, which you all may not know about him, that when Sir was the president of MOGS, at all his conferences as youth council members, he always gave us an opportunity to be a part of each and every conference, and not just as masters of ceremony. He allowed the youth council to be a part of the inaugurations, being the chairpersons. So Sir's always had a forward-looking process. And Sir, thank you for all the opportunities we've always got. So over to you for your topic.
Thank you very much, Rohan, again for that very kind and generous introduction. And I think Dr. Hema Divakar mentioned, but I must reiterate the really wonderful moderators I have in, sorry, right, in Rohan, Priyankur, Niharika, and Apurva. Actually, I should have said it the other way. I should have said the ladies first. So Apurva, Niharika, Priyankur, and Rohan. I'm really blessed to have them as my moderators, and they're really very hardworking. And in fact, I think it's fair to say that this series would not really have been possible without them. I'm delighted that Dr. Hema Divakar took time off to share some of her thoughts with us, and it's always such a pleasure to hear her and interact with her. I'm also very much looking forward to Dr. Abharani Sinha's talk on fetal neurodevelopment and nutrition. I have always admired her since so many years, and I'm really looking forward. Madam, thank you for agreeing to give this presentation. And then we are really going to have this wonderful panel moderated by one of our most enthusiastic, dynamic, and capable members, Dr. Mitra Saxena from Rewari, with really a star-studded panel discussion with Dr. Poonam Khera, Dr. Prema Dekunna, Dr. Tejavati, Meera, Dr. Neelam Mishra Madam, Dr. Madhulumba Madam, and Sunil from Ahmedabad. So all in all, we are looking forward to a great program. And I'm happy that as I begin, there are 4,556 people logged in for the program today. And I hope that the time that you spend with us is well worth the time that you have taken out. So I'm going to speak on IUGR, a clinical approach. I'm really not going to get into the theory of IUGR and the pathophysiology of IUGR, say for one slide. What I'm going to try and do is give an idea about what is the state of the art, both in the detection of IUGR, and once the IUGR is detected, what do you exactly do when you have a patient sitting in front of you and you have to make the decisions which surround either her SGA fetus or her growth restricted fetus? And that's really a very, very important distinction. I remember reading the annual report of Reliance Industries Limited, one of the largest corporate conglomerates in our country. And I was really impressed with this tagline, which they used to have in their annual report for several years, which said, "Growth is life." And I think all of us will agree that one of the major concerns which pregnant patients and their relatives have when they come to us is, "Doctor, is my child growing well? Is my fetus growing well? आनी विकास सारो छे के नहीं, बच्चा ठीक से बड़ा हो रहा है या नहीं, and in all the other languages, because growth in this instance is really equated with life. Let me also clarify this one thing, that the reduction of morbidity from IUGR does not result from the management of the acute disease, but mainly from the screening and intervention that comes with organized antenatal care and, generally speaking, the improved health of the community. And this statement is intended to move the lens away from a purely clinical perspective and a move, if you may say so, into the public health perspective, which essentially says, as Dr. Divakar said, that we need to look at the entire health ecosystem if we are going to reduce the morbidities that result from infant growth restricted fetuses. But first of all, let me reiterate that there has been a paradigm shift in the way we look at IUGR. We now are no longer supposed to say IUGR. We are supposed to say SGA. That means fetuses with an estimated weight of less than the 10th percentile are fetuses which are small for gestational age. And within this whole small for gestational age, you may either have constitutionally or pathologically small fetuses. And it's the pathologically small fetuses who really have the bulk of the morbidity. To wit, if there is an SGA or a small fetus with no maternal pathology, with normal umbilical artery and MCA Doppler studies, then that is not a pathologically growth restricted fetus. It is a constitutionally small fetus. Growth restricted fetus is a fetus which is small with a recognizable maternal pathology or an abnormal umbilical or MCA Doppler. When there is no maternal pathology present, but there is an abnormal fetal Doppler, then you have the idiopathic growth restricted fetuses. And I believe that this is a paradigm shift because it recognizes the fact that not all small fetuses are pathological. I sometimes see patients where the husband is 5 feet 6 or 5 feet 7, the wife is around 5 feet 2, 5 feet 3, and then the report comes back saying that the fetus is small. And I think this illustrates the point that if you are going to have constitutionally small parents, there is a likely chance that the SGA fetus, which is reported on ultrasound for them in terms of biometry, not Doppler, but biometry, is probably a constitutionally small fetus rather than a pathologically small fetus. But it's the pathologically small fetus or the fetus who has FGR, fetal growth restriction, which is the one which we really worry about because these are the fetuses who are at a greater risk of stillbirth, birth hypoxia, etc. But, and again, an important point when you look at the literature which surrounds IUGR and SGA fetuses in general, it's quite possible that because this distinction is relatively new, studies on SGA fetuses which have shown poor perinatal outcome is likely to be the high incidence of true FGR in this group. It remains true, however, because of this distinction, that the vast majority of term SGA infants have no appreciable morbidity or mortality. So let's not jump the gun when we are looking at SGA fetuses. I promised you that I'll have only one slide on pathophysiology, and this is this. And this slide is important for the first sentence, which says that the fetus responds to chronic hypoxemia in a predictable sequence that is correlated with acidemia from blood gas. And it is this predictable sequence where there is an abnormality in the heart rate, an absence of breathing, cessation of movement, and then an absence of tone, which is what is utilized to a certain extent along with Dopplers to make a diagnosis and detect abnormalities in pathologically growth restricted fetuses. Remember, it is still very challenging to either predict or prevent an acute hypoxemic event. When we do Dopplers, etc., what we are essentially looking are either the end results or the progression of chronic hypoxemia. So if you have a patient who comes to you in early pregnancy, the first thing you need to do is triage them into the risk factors which are outlined in this quite wonderful guideline produced by the Royal College on SGA fetuses. Women who have a major risk factors should be referred for serial ultrasound of fetal size and assessment of well-being from 26 to 28 weeks of pregnancy. And if there are 3 or more minor risk factors, as outlined in this table, they should be referred for uterine artery Doppler at 20 or 24 weeks of gestation. If you look at some of the so-called new markers, which either predict an SGA fetus or diagnose one, you will see that the second trimester DS markers have a limited predictive accuracy for delivery of an SGA neonate. However, a low level of the first trimester marker PAPPA could be considered to be a major risk factor, but it's a risk factor. It's not a diagnosis. And again, that distinction is very important. If you have a fetus with echogenic bowel, then that fetus should be subject to serial ultrasound measurement of fetal size and assessment of well-being with umbilical artery Doppler. So those are the high risks. That is the triage of when you have to look out. If you want to detect IUGR, and I must confess here that as clinicians, because most of the times we rely only on abdominal palpation, we are sometimes quite terrible at detecting IUGR. And that is why a high index of suspicion is quite important. These are the other tests that you use to detect IUGR, and let's look at them one by one. As I've already said, abdominal palpation has a limited accuracy for the prediction of an SGA neonate. So what you should really be depending on is a serial measurement. And that word serial is quite important. It's not one single measurement, it's serial measurement of the symphysis fundal height from 24 weeks of pregnancy, plotted on a customized chart rather than a population-based chart. And this may improve your prediction. Women with a single SFH which plots below the 10th centile or serial measurements which demonstrate slow or static growth should be referred for ultrasound measurement. Remember, there will be a small subgroup of patients where the measurement of symphysiofundal height is going to be inaccurate. For example, patients with very high BMI, patients who have fibroids, patients who have either too much liquor or too little liquor. And if you know that the patient has this, then don't rely only on symphysiofundal height. Go ahead and do a serial assessment with ultrasound. Uterine artery color Doppler is something that has gained a lot of traction in recent times. I hardly ever now see an ultrasound report where a uterine artery color Doppler, particularly at the time of nuchal scan and in the late second trimester, is not talked about. But remember that in high risk populations, uterine artery Doppler at 20 to 24 weeks has a moderate predictive value. By no means is it something that is cast in stone. If there are women at this point in time who have an abnormal uterine predictive uterine artery Doppler, and then later on have a normalization of the flow velocity indices, they are still considered to be at an increased risk. The operative word being increased risk. Repeating uterine artery Doppler is therefore of limited value. So if you've done it once at the late second trimester or early second trimester, then there's really no point in doing it again and again. Women who have an abnormal uterine artery Doppler at 20 to 24 weeks should be referred for serial ultrasound measurement and assessment of well-being with umbilical artery Doppler. And remember these again, sometimes while reading uterine and umbilical do get confused when you read the reports. Make sure that you underline that to make, understand exactly what it is you are reading about. Remember that uterine artery Doppler has a very limited accuracy to predict adverse outcome in SGA fetuses diagnosed during the third trimester. So if you want to have a optimum usage of making a diagnosis, it's the fetal abdominal circumference or the estimated fetal weight, which is less than the 10th centile, which should be used to diagnose an SGA fetus. Although a customized fetal weight reference may improve prediction, the routine measurement in the third trimester really does not reduce. It is more than the single measurement, it's the change in the abdominal circumference or the estimated fetal weight, which actually improves the prediction. And if you are going to do serial measurements, it is best to do serial measurements at least 3 weeks apart. If you do measurements too often, you are going to get false positives because there are going to be variations in 1 or 2 millimeters or 1 or 2 centimeters by the sonologist, and that may give you either a false positive or a false negative kind of an outcome. If you find that there is a fetal AC or estimated weight which is less than the 10th percentile, then offer serial assessment of the fetal size and umbilical artery Doppler. Remember that there will be a certain percentages of fetuses, around 19%, where if the ACI and EFW is less than the 5th centile, they may actually have chromosomal defects, and therefore they will need to be investigated with that, with an anatomical survey as a minimum, and karyotype in severely SGA fetuses with structural abnormalities. Remember also that there could be other reasons for SGA fetuses. You may consider serological screening, testing for syphilis and malaria. For me, however, the problem with all these Doppler studies and serial measurements, etc., has always been this. First, make sure that your estimation of the gestation is absolutely accurate. That means the patient is very sure of her dates and also has a first trimester ultrasound to back up those dates. Most tests, as I said, attempt to diagnose SGA rather than growth restriction. And most of the studies which report on IUGR have actually not differentiated between constitutionally and pathologically small fetuses. Again, very important that an individual test alone may not be predictive of SGA or FGR, but a composite of abnormal results like an ultrasonically small fetus with reduced Leica. I consider reduced Leica to be a very important landmark, or abnormal uterine artery Doppler may indicate pathology. So how do you manage this patient who is sitting in front of you? When an anomaly scan and umbilical artery Doppler are normal, the small fetus is likely to be a normal small fetus or a constitutionally small fetus. The frequency of monitoring in SGA with a normal Doppler should not really be more than once every fortnight or once every 15 days. When end diastolic flow is present, one must try to delay the delivery until at least 37 weeks, provided other surveillance findings, especially amniotic fluid index or single deepest pocket of amniotic fluid, is normal. If end diastolic flow is absent or reversed, admission, close surveillance, administration of steroids if the patient is preterm, or if the patient is advanced in gestation, then of course you need to consider delivery. If the gestation is over 34 weeks, even if other results are normal, if there is particularly a reversal of diastolic flow, you should consider delivery. So umbilical artery Doppler should really be the primarily surveillance tool in the SGA fetus. The CTG should not be used as the only form of surveillance in SGA fetuses. How often should you do the, the Dopplers? Well, if you look at it, this chart, you will see that it depends on what the finding of the Doppler is. If it's high S by D and she's less than 26 weeks, then you test at 26 weeks. If she's 26 to 32 weeks, repeat after 15 days. And if she's more than 32 weeks, repeat after 7 days, because the fetus is that much more viable at that time. If there is an less than 26 weeks, test at 26 weeks. If she's between 26 to 32 weeks, either consider repeating after 72 hours, or depending on the NICU backup that is available to you, plan a delivery. If she is more than 32 weeks, consider delivery. It's written repeat next day here, but I would actually not repeat it the next day. I would consider delivering that fetus. At the most, I may wait for some time to give either Maxel or steroids and then go ahead and deliver the fetus. If there is a reversal in the end diastolic flow, the operative word is delivery if possible, depending on the NICU backup. The gray area really comes if the fetus is less than 26 weeks. And over here, it is the counseling which really plays an extremely important role. Should you give steroids and also use neuroprotection? The short answer is yes. We have spoken about this in one of the sessions earlier, so I'm not really going to belabor the point. Just a word or two about NSTs, particularly in IUGR. Remember that you should always use a stethoscope, particularly in pathologically growth restricted babies before you start the NST. Remember that the NST machine relies on the autocorrect function, and it could sometimes be picking up the maternal heart rate, doubling it to autocorrect it to fit into the normal fetal profile. And you may be actually seeing the maternal heart rate as the fetal heart rate. Always use a stethoscope and always ask the patient if the movements are okay before you start doing the NST. Another practical tip is always look at the paper speed when you have an NST. An NST done at 1 centimeter per minute paper speed and 3 centimeter per minute paper speed look very, very dramatically different. If you find that you have a very wide spaced out and less variation in your fetal heart rate or variability in your fetal heart rate, always look at the paper speed first. As I said, I consider amniotic fluid to be an extremely important indicator. And if you are going to use amniotic fluid as one of the markers, then if you are looking at uh, AFI, then if you're looking for oligoamnios, try and look at the single deepest pocket rather than the AFI. A lot really has been said about adjunctive therapy, not only in IUGR, but in obstetrics in general. And I really like this quote from Irma Brombeck. And she says, when your mother asks, do you want a piece of advice? It's actually a mere formality. It doesn't matter if you answer yes or no, you're going to get it anyway. So adjunctive therapy in obstetrics, particularly for conditions like IUGR, etc., are more or less, you are going to get it, irrespective of whether you want it or not, and therefore always keep the principles of empirical therapy in mind. Do no harm, do not waste too much money, do not waste too much time, and base your empirical therapy on at least a modicum of logic. What has been shown to work? Interventions to promote smoking cessation may prevent delivery of an SGA infant. Antithrombotic therapy appears to be a promising therapy, and it's a big but, there is insufficient evidence, especially concerning serious adverse effect, to recommend its use. The use of low molecular weight heparin for IUGR empirically should really be considered with a very grave thought before you institute it. Aspirin is something which we give day in and day out. We use a lot of aspirin in our practice. However, the truth is further trials are actually needed to assess the value of aspirin in the treatment and both prevention of FGR. There may be, however, a small role of aspirin in preventing SGA birth in women at a high risk of preeclampsia. Remember, this is not a very large subgroup of patients. So although it may not work universally, in patients who are at high risk of preeclampsia, aspirin could work very well. Quite clearly, there is not enough evidence to assess the value of oxygen, nutrition, bed rest, beta mimetics, calcium, progesterone, plasma volume expansion in treating growth restriction. Remember, first do no harm, because most perinatal interventions actually do not show any significant effects on perinatal outcome. It then becomes that you have to decide what is the optimal time for delivering the SGA fetus. So in the preterm SGA fetus, if your umbilical artery absent reverse end diastolic flow is detected prior to 32 weeks, delivery is recommended when ductus venosus Doppler becomes abnormal or UV pulsations appear, provided the fetus is considered while and after completion of steroids. Now, this is where individualization comes in, because to a certain extent, this will all depend on the NICU care that is available to you. I believe everybody's threshold for delivery in prematurity has to be different depending on the NICU backup that you will get. How should you deliver the SGA fetus? If there is an absent or a reverse end diastolic velocity, then obviously you will have to do a cesarean. In an SGA fetus with normal umbilical artery Doppler or with abnormal umbilical artery PI but end diastolic velocity present, you can offer an induction of labor, but keep in mind that even after offering induction of labor, the ACCS are going to be increased. And if you are perchance giving a trial of labor, admit that woman early and make sure that you monitor the fetal heart very well. Even if you are going to do a cesarean for an SGA baby, remember that this may not be the same as doing a cesarean for AGA or a LGA baby at term. You will probably have an unformed lower uterine segment, so you will have to actually cut quite deep into the lower uterine segment. You may have less liquor. There might be a non-vertex presentation. These patients, because of the unformed lower uterine segment, are prone to extensions, atony, and PPH. And because you need to cut a lot, and sometimes there is a fair amount of bleeding, and sometimes you are in a hurry to deliver that child, you may land up nicking the child and creating neonatal injuries. So, in these kind of instances, what I would say is that don't start with a very small incision on the lower segment. Take a little broader incision with the knife and make sure that you cut all the layers in the entire length of the incision. Make sure you suction that area properly or put a mop before you make the next nick. And when you feel that you're getting closer to the membranes, use your fingers and separate the layers till you reach the membranes. Try to avoid rupturing the membranes with your knife in these circumstances, and you'll make sure that you never get a neonatal injury. When you have to do this cesarean, have a mental image of the lie and presentation. Make sure your abdominal incision is adequate, paradoxical, because you are going to deliver a smaller child here. The lower segment approach is, of course, preferable and feasible. And when you're going to extend the incision, as I said, take a little longer incision with the knife, cut layer by layer till you think you reach the membrane, then go in with your finger and then extend the incision with scissors. And when you're doing it, turn the scissor upwards at the end so that you don't extend into the uterine artery. If it's a non-vertex, don't try to convert to a vertex, apply a forceps and deliver. Go for the feet and deliver by a IPV. You need to be a little quick here because if you let the liquor drain out, it becomes quite difficult to turn the baby around. If it's going to be a vertex, then I always prefer to use the forceps because I think it is very safe and effective. So in effect, what has happened is that we have turned really a full circle. Once IUGR is identified, obstetrical management is focused on assuring safety while the fetus continues to mature within a potentially hostile intrauterine environment. There is really no single test that seems superior to the other available tests for timing the delivery of the growth restricted fetus. And as I already said, the decision to deliver the fetus, especially when it's less than 32 weeks, remains mostly on the basis either of empirical management or on the NICU or the neonatal care that is available to you. So let me end with one of my favorite quotations that the trouble with so many of us is that we underestimate the power of simplicity. We tend to mistake movement for achievement. As I've illustrated, it's all about keeping the fetus safe inside with basic tests, and that's really what we need to do in the clinical management of IUGR. Thank you very much.
Thank you so much, sir, for such a crisp and clear talk and for giving us so many practical messages during our own practice. Without taking too much time, I'd like to introduce our next speaker. Could I have Abharani ma'am's slide, please? Today's so again, ma'am, thank you for accepting her invitation for the program. And again, ma'am needs absolutely no introduction. She's a professor of OBGY at SKMC Muzaffarpur. She's a ICOG Governing Council member, the president of Patna OBGY Society 2017-2018, and she's also been the chairperson quiz committee of FOXY 2015-2017. You can see ma'am has a lot of accolades to her name, but without taking too much time, ma'am, I request you to please begin your talk.
Okay, should I share my screen?
Yes, ma'am, please.
Okay, thank you so much, Rohan. And at the outset, I'd like to thank Dr. Jaideep Tank and his very vibrant team for making me a part of this O2S Masterclass webinars. So, well, My talk is on fetal neurodevelopment and nutrition. I know it's not going to be a mesmerizing talk like Dr. Jaideep Tank's, which was totally clinical. I have to go into some of the theoretical aspect of fetal neurodevelopment. So today I will be talking about fetal neurodevelopment, a bit about fetal programming, and then the role of nutrition in fetal neurodevelopment, and there will be certain key messages. So first of all, I would like to say that one of the most important long-term health outcomes of early life experience is neurodevelopment. And brain development in early life is highly pre-programmed. The fetal brain is particularly plastic, whereby even subtle changes in structure and function produced by the in utero conditions can have long-term implications. And there are environmental factors that profoundly influence early brain development, which includes nutrition, reduction of toxic stress, and environmental enrichment. Of these, nutrition can be optimized by us, the caregivers, to promote neurodevelopment. So now, few words about fetal neurodevelopment. It is the prenatal period which represents a time of extremely rapid changes in brain development. During the gestation, neurogenesis can occur at an astonishing rate of over 1 lakh new cells per minute. And these rapid neurological advances render the fetus susceptible to various influences with lifelong implications. If we look at the neurodevelopment, the human neurogenesis, it initiates on embryonic day 42 and is complete by mid-gestation. And it is around the 8th gestational week that neuronal migration starts. And by the 20th week, axons are formed with synapses with the cortical plate. And by 24 weeks, cortical circuits are organized. And by gestational week 28, the human brain contains billions of neurons, which is 40% more than in the adulthood. And so, before trimester and after birth, the brain directs the elimination of unnecessary neurons. Now, this apoptosis is also very important. The brain undergoes a remarkable transformation in form and function. And this all begins at approximately 23 to 24 weeks post-conceptional age through the first 2 years of life. And here we have this concept of 1,000 days, which consists of the whole of the antenatal period along with the first 2 years of life. And it is in these 1,000 days that the majority part of the brain is developed. And from 24 to 40 weeks, what we find that the brain changes from a smooth, bilobed, and relatively non-complex organ into one which is characterized physically by the sulci and gyri, which are the more typical of the adult brain. Now, this increased physical complexity, it reflects the rapid rate of neuronal and glial growth and development within the brain. And as these cells become more complex and interconnected, the brain functional capacity increases. Now, the time period, which starts in the last trimester of pregnancy and progress through the first 12 to 24 months post-term, is characterized by the development of primary circuits. And these primary circuits serve important functions. The brain regions and processes that are rapidly developing during this time period include the hippocampus and the striatum that supports the fundamental, declarative, and implicit learning. And the other process, that is the myelination, supports the speed of processing. And the monoamine neurotransmitter systems, they support the reward processing. What we see is that some fundamental behavioral functions, such as hearing, touch, and pain sensation, taste, and to a lesser extent vision, they are already present at birth, which indicates that structural connectivity of the relevant brain circuits have begun. However, more complex behaviors such as recognition, memory, they are also dependent in large part on hippocampal development. These can also be demonstrated in the term and preterm neonate. Now, the neural circuits underlying more complex behaviors that will appear later in the childhood, such as working memory, set shifting, multitasking, and attention that are not present in the neonate also have their neural ontogenesis prior to the term birth. So coming to the fetal programming, the concept of fetal programming describes the process whereby the fetus senses, receives, and responds to the intrauterine environment. And this during sensitive periods of development, the fetal programming can produce structural and functional changes in the cells, tissues, and organ systems that may independently or through interactions with subsequent developmental process and environments confer a critical long-term consequences for future health and disease susceptibility. So what we see is that the developing brain is sensitive to fetal programming effects because the vast majority of differentiation of major brain structures occurs during the prenatal life. And this is orchestrated by a cascade of bidirectional interaction, which is occurring between the maternal compartment and the fetal compartment along with the external environment. There is also role of epigenetics. So background genetics and epigenetics, they also determine the individual's level of need and ability to metabolize a given nutrient. Therefore, full consideration should be given to the prenatal nutritional environment. Both prenatal and postnatal nutrition should match, as the fetus is most likely programmed epigenetically for a world that will provide a similar nutritional experience. So what we see that maternal nutrition plays an important role in fetal brain development. All nutrients are important for structural and functional brain development, but those that support energy, carbohydrate, protein and fat metabolism are of particular importance. Along with this, the substrates that support mitochondrial health are relevant because mitochondrial function appears to be programmable in early life, and thus it may influence the lifespan health. Perinatal events that affect hippocampus and striatal integrity, such as nutrient restriction, result not only in abnormal function of these primary areas, but also in abnormal frontal lobe function. And therefore, we can see attention deficit, hyperactivity behavior phenotypes in middle childhood, and they are more prevalent following intrauterine growth restriction. So the positive or negative effects of nutrients on the brain are based on the timing, the dose, and the duration of the exposure. The brain is not a homogeneous organ. Rather, it is made of distinct regions like hippocampus, cortex striatum, cerebellum, and certain processes like myelination, neurotransmitters, and each of which has a different developmental trajectory and a set of nutrient requirements. So nutrients that affect the anatomical structure through signaling pathways such as mammalian target of rapamycin. This mTOR pathway senses the status of important metabolic substrates such as amino acids, iron, glucose, and oxygen, and integrates their inputs through a multiple kinase-driven system to determine the rates of actin polymerization, protein translation, DNA transcription, and autophagy. And this actin polymerization is key to axonal and dendritic structural development. And it is well recognized that dendritic structural complexity correlates closely with function. So there are certain nutrients which have its effects on the brain anatomy, and some have their effect on the function. So the nutrients which have a profound effects on the brain anatomy are iodine, zinc, copper, choline, vitamin A, and long-chain polyunsaturated fatty acids. The nutrients also affect the function of the brain through their effects on the neurotransmitter concentrations, receptors, and reuptake mechanisms. And the nutrients that particularly affect the neurotransmitter functions are protein, iron, zinc, copper, and choline. Apart from this, the nutrients, they also affect the electrophysiologic potential of neurons through their effects on the metabolic rate. The electrical potential generated by neurons is a highly energy taxic process, and it relies on healthy mitochondria generating adequate amounts of ATP. Whereas all nutrients are needed for the development and function of the brain, there are certain nutrients which have a high impact on early brain development, and these include protein, fats, iron, zinc, iodine, and vitamin B12. Nutrients that support the oxidative and glycolytic metabolism are in high demand in the developing brain, and these include the glucose, protein, iron, and zinc. And especially in the early gestational age, the demands of the nutrients are very high, and also in the early postnatal phase. And the positive or negative neurobehavioral effect of these nutrients, they will depend on the timing, dose, and the duration of either provision or deprivation. So optimizing nutrition during fetal and early postnatal life is a golden opportunity to impact neurodevelopment and brain function across the lifespan. Now, coming to the role of iron, iron deficiency in the maternal diet may be responsible for hippocampal development changes and for altered myelination, ending with altered speed of processing. It has also been associated with a lowered monoamine neurotransmitter synthesis that may result in pathology of motor activity. And it has also been found to adversely affect cognitive, socio-emotional, and behavioral development. Protein deficiency in the mother's diet may affect the development of specific cerebral areas, which include cerebral cortex and hippocampus, leading to deficient recognition and memory persisting in childhood and even adulthood. Zinc is important for neuron formation, migration, and synapse generation, and zinc deficiency may lead to decrease in DNA and RNA synthesis, changes in autonomous system regulation, and to truncation of dendritic harbors, ending with a deficit of astrocytic functions in multiple brain areas. Iodine is very important, especially in the preconceptional period and early gestational period, because the thyroid hormone is not present in the fetus, and it is mainly from the maternal source that it is coming. So iodine is very important right in the early period of gestation, and its deficiency can disrupt the fetal neurogenesis, neuronal migration, synaptogenesis, and myelination. Coming to the role of DHA, that's very important. A shortage in the maternal diet during gestation of dietary fatty acids has been reported to interfere with fetal brain neurogenesis, neuronal differentiation, synaptic plasticity, and ion channel formation. And low dietary intake of DHA during pregnancy have been associated with changes in gene expression in the developing brain, leading to altered molecular and morphological cerebral development, ending with long-term implications to brain functionality later in life. The fetal brain is dependent on sufficient provision of maternal folate during embryogenesis. We all know that if there is folate deficiency, it can compromise the delivery of folate to the developing brain. And depending on the degree of deficiency, there could be a spectrum of neurological abnormalities, which could range from full-blown NTDs to more subtle changes that manifest in childhood as behavioral abnormalities. Again, choline is also very important, because if there is a maternal diet low in choline, it increases the risk of neural tube defects in the developing fetal brain, leading to low performance on cognitive tests in children. There are dietary deficiency of critical methyl donors, which include folate and choline, in pregnant mice has been associated to increase apoptosis in neurons of the fetal hippocampus, leading to hippocampal dysfunction and memory deficits in the offspring. This is just a flow diagram showing the deficiency of the important nutrients like protein, iron, PUFA, choline, and zinc. And the final effect could be motor deficits, intellectual disturbances, deficient recognition of memory, altered speed of processing, autism spectrum disorders, cognition and emotion changes, and changes in motor activities. And here we can see that apart from the nutrients that I have mentioned, it is also important to have enough of vitamin B6, B12, and vitamin D in the diet. Studies have shown that those fetuses who have deficient D during their gestational period can develop schizophrenia later in their life. This is another chart showing the effect on the chemistry and physiology and metabolism of brain when there is deficiency of nutrients. So as I had said earlier, the timing, dose, and duration of nutrient intake is very, very important, because there is a sensitive period for nutritive action, and some may even reach the level of critical periods. And if a certain nutrient is not received at that particular time, the results may be profound and at times even irreversible. So now something about the preconceptional period, I think that is also a very important time in which the women should have good nutrition and proper nutrition, because proper nutrition, it supports the rapid cell division, the development of supporting structures, and neural tube closure that occurs in the first few weeks. Therefore, it is important that women of childbearing age should have proper nutrients on board in the event of an unanticipated pregnancy. Now, apart from malnutrition and undernutrition, obesity is also very important, because obesity can also lead to neurodevelopmental disorders. If there is increased maternal IL-6, TNF, it causes increased maternal IL-6, TNF, alpha, leptin, and all these can cause an increase in placental serotonin, reduced fetal axonal outgrowth, and finally, they may be at increased risk of neurodevelopmental disorders. So we have to have a check on obesity also in the intrauterine period. Now coming to the research, well, whatever study has been done, they are not much of evidence-based. Most of these studies have been done on animal models. So now the researchers from the Department of Bioengineering, Pediatrics, and Radiology are imaging the structural connectivity of the brain. The team is studying the fetal brain over 20 weeks when both brain anatomy and the function are changing dramatically. They are working on how the physical wiring of the brain is being developed and its increasing connectivity, as well as the pruning of connections and how the connections get refined before birth. In one project, they are even examining, which is taking place in the Washington University, they are examining the effect of mother's diet during pregnancy, specifically looking at the protein levels and what might happen if protein is restricted. Even resting state functional MRI has opened up a new avenue for non-invasive assessment of neural functional connectivity before birth. And these are a few pictures. These are motion center diffusion-based MRI images, which shows how structural connectivity of the physical wiring of the brain and its connection changes over pregnancy from week 20 to week 35. With the colors, we can see the direction of the flow. The red is showing from left to right, the blue colors are from up to down, and the green are showing from front to back. So I would like to say that ensuring adequate fetal loading of nutrients through better maternal care during pregnancy via provision of adequate nutrition, reduction of obesity, hypertension, and glucose intolerance appears to be key to fostering postnatal nutrient insufficiency. Early life nutritional deficits can affect brain function across the lifespan, and this loss of brain function is the true cost to society of early malnutrition. And there are substantial evidence in preclinical models which exist for several nutrients, including protein, energy, iron, choline, and PUFAs, that early life deficiency confer neurologic risk well beyond the time of deficiency and in spite of complete nutrient repletion. And this risk includes altered developmental trajectory resulting in adult dysfunction. An important issue is to identify more precisely the sensitive time window. This is very important because within which to provide nutritional interventions in order to promote optimal neurodevelopment in children. Postnatal nutrition success is highly dependent on optimizing the fetal nutritional status prior to birth. So nutrition is important during pregnancy for laying the foundation for the development of cognitive, motor, and socioeconomic skills, socio-emotional skills throughout the childhood and adulthood. So I would like to end by saying that proper neurodevelopment is like an orchestra. Every molecular pathway during brain development must work at the right moment and in the right place. Deficient nutrition is likely to destroy this harmony, to alter several molecular pathways and alter brain structures and their physiology during development. Thank you. Thank you so much for giving me the opportunity.
Thank you very much, madam. I know that this is a very, very difficult topic, but I must say you really did justice to it and brought out so many practical aspects of the whole thing. Thank you very much for accepting to give this presentation and then doing such a wonderful presentation on top of it. Thank you very much, madam.
Thank you, sir. Thank you.
Thank you so much, ma'am, for such a wonderful talk. I think so can we take one question for
Uh,
you?
yes, Ron, you can. I think you can take up to 4 or 5 minutes. That's fine.
All
For
right.
if there are questions.
Yeah. One question which is there is, sorry, should sildenafil be used in oligo IUGR and reduce flow, and how to decide the dose?
Okay, I think this is where we sort of go into that empirical therapy, which I talked about. And I mentioned that it's like advice from your mother, whether you like it or not, you're going to get it. That kind of a thing. And I really doubt whether there is any evidence to show on a concrete basis that sildenafil is really, really useful. And so I would actually hesitate to make any recommendations which surround it. Over here, I would go with the basic principles of empirical therapy of saying first, do no harm. Don't spend too much money. Do not waste too much time, as I have already said. Personally, I don't use sildenafil at all for IUGR, but I must again confess that I also don't use it in IVF for endometrial blood flow or anything of that sort. Not a big fan over here for its, how should I say, non-conventional use, if I may say so, of sildenafil over here. So
Ab-
again, no evidence for that really, Rohan.
Absolutely, sir. Thank you. So there's another question for you from Dr. Maninda Ahuja from Faridabad. She's asking, how should we give steroids in a diabetic mother with SGA fetus?
Okay. Hi, madam. Good evening. Always good to hear from you. The answer is actually just like you would for anybody else. The benefits of giving steroids in prematurity, particularly in women who are diabetic, far outweigh the risks of either having an uncontrolled rise in sugars or infections for these women. So for these women, like you would use steroids for like you would for any other women. Remember, however, that the steroid of choice is betamethasone. The other steroid, betamethasone or dexamethasone, with betamethasone being the steroid of choice. The other steroids don't really help in any way whatsoever.
Thank you, sir. Abha ma'am, we have one question for you from Dr. Kiran Sinha from Kanpur. Is the supplementation of DHA recommended in the first trimester? She says that she generally supplements with DHA from the second trimester onwards.
Yes, because most of the brain development, they start from the 24 weeks onwards. So I think it's better to give it from the second trimester. But it has to be continued all throughout the pregnancy.
All right, ma'am, the follow-up question is, do we continue it during the breastfeeding period as well, or we stop it after delivery?
Usually it is continued throughout the period of pregnancy. Usually we do not give it during lactation.
Thank you so much, ma'am. I think also another question from Dr. Shubhangi Nirkhawale from Indore. Is there any role of L-arginine in IUGR?
Again, this falls under that empirical therapy kind of a thing, but I must confess that from whatever little anecdotal experience I've gathered in practice, if anything seems to work, it is L-arginine. One has tried just about everything for IUGR, but L-arginine seems to work, particularly when there is associated oligoamnios. I'm not going to say it's a miracle drug and it should be routinely used for IUGR. That would be obviously the wrong thing to say in terms of evidence. But from all the things that I've used so far, that is the one thing that I use in IUGR and borderline LICA measurements.
Thank you, sir. So one last question from Dr. Shilpa Agarwal from Mumbai. If PPROM is present and there's a high WBC count, should steroids be given?
It pretty much depends on what exactly is the gestational age and what are the chances of viability. So I would tend to divide these patients into those before 28 weeks and those after 28 weeks. After 28 weeks, even if she's got PPROM and I'm considering a delivery because of whatever reason, I would give the steroids, even if the WBC count is high, because remember that the WBC count could be high without any reason in pregnancy. And a rise in WBC count does not correlate with the presence of chorioamnionitis, nor does it predict chorioamnionitis. However, if she is less than 28 weeks and I'm not considering a delivery immediately, then of course I would not give steroids to that patient. So I would not base my decision on the WBC count. I would base my decision on the clinical findings: non-tender uterus, no foul smelling, discharge, and good movements, and a short duration of PPRN. The question that would arise in this instance is whether to do a high vaginal swab or not. And opinion quite clearly is divided about this. If you do a high vaginal swab in these cases, you will probably get a positive result. And then you will wonder whether to give steroids or not. So I guess the easy answer, Rohan, would be not to do the high vaginal swab if clinically it's not indicated.
Absolutely, sir. Thank you so much, sir. That was the last question, and I think so. There are a lot of compliments from a lot of from all of the delegates for you as well as Abha ma'am for such amazing talks. I think we'll end the question and answer session here, sir. And before we just move on to the panel, Maruti, our educational partners, Torrent Pharma, could I request them to just play their video before we move on to the panel?
Sure, sir.
The triangle of B complex is essential for pregnant women in their dietary process, as while conceiving, women find it difficult to produce adequate levels of vitamins. With external supplements, they get their required dosage, which is ready for absorption and utility by the body. Vitamin D also is most crucial in pregnancy and lactation. For prevention from adverse outcomes, future risk to health of child, and maternal and fetal health during pregnancy. European Society for Pediatric Endocrinology confirms vitamin D3 2000 IU per day ensures adequate vitamin D status in pregnancy and early infancy. Vitamin D3 supplementation helps achieve the sufficiency and can be taken for a long duration. Calcium also plays an important role in pregnancy as its twofold requirement increases. Adequate maternal health is needed for fetal bone health, and as per the BMC Public Health article, calcium supplementation during pregnancy reduces gestational hypertension by 45% and preeclampsia by 59%. Effective management of pregnancy demands supplementation of prenatal vitamins. This supplementation provides protection against various defects that can occur during pregnancy. Shellcal XT provides protection against neural tube defects. It reduces the risk of preterm birth and congenital heart diseases. Shellcal XT contains 1,250 mg of calcium carbonate, which is required to maintain maternal skeletal calcium. 2,000 IU of vitamin D ensures adequate status in pregnancy and early infancy. Shellcal XT has 1,000 micrograms of L-methylfolate. Journal of Clinical Pharmacology and New Drugs confirms that L-methylfolate helps in decreasing the risk of NTD by 72%. The methylcobalamin at 1,500 micrograms improves pregnancy outcome and maintains normal folate metabolism. The additional pyridoxal 5-phosphate at 20 mg reduces nausea and vomiting in pregnant women. From preconception, pregnancy to lactation, Shellcal XT is a world-class product for vitamin supplementation. Shellcal XT has special coating technology and vitamin D3 in stabilized form. Shellcal XT helps to reduce the pill burden. Dosage of Shellcal XT is 1 tablet once a day. Each ingredient in Shellcal XT is coated separately, so there is no drug-to-drug interaction. Shellcal XT scored tablet gives dosage convenience. A healthy start leads to healthy mothers, and healthy mothers make a healthy generation. After all, every pregnancy is precious.
Thank you so much. I'd like to thank Torrid Pharma for being the educational partners for this entire O2S webinar series. And now I'd like to move on to the panel discussion. It's going to be on vaginal delivery. And we've got Dr. Mitra Saxena, ma'am, who's going to be moderating the panel. May I request you to please display Mitra Saxena ma'am's CV, please? She's the director of the Sri Ashwini Saxena Hospital in Revri, and she's the chairperson elect of the Practical Obstetrics Committee, FOXY 21 to 23. She's been an active FOXY member since last 20 years, and she's been very active throughout all the societies in which she's been a part of. And she has a project director of Mukti, which was an initiative of the Haro OBGYN to increase the awareness about freedom from unwanted pregnancies, breast cancer awareness, and cervical cancer. Ma'am, over to you for the panel.
Yeah, thank you, Dr. Rohan, but I am unable to share my screen and I'll be needing some assistance.
Madam, you'll be able to do it because that screen
No,
share.
actually, I'm not able to see my desktop. So I was asking that what should I do? I'm not able to see my desktop. So should I leave this and join again?
Ma'am, just cut the share screen and press the share screen button once again.
No, I'm not able to see my presentation. I think I will
Is
need
it
to leave it.
open in the backend?
Sorry, just 1 second. Okay. Is it visible?
No, ma'am, not yet.
Now you can see the share screen. If you have opened the presentation, now come back to Zoom, ma'am, and do share screen.
I am unable to see.
Ma'am, maybe once
Madam, you can email that your presentation to the technical team.
Okay, I'll do that.
Ma'am, what you can do is, I think maybe what you can do is you can leave and join back. And
Yeah,
we'll
I think that should be easier. Huh? 1 second.
any other
I'm very
questions.
sorry. I was asking the team
No
while the
problem,
talks were
madam.
on,
Yes, that's
but
fine.
I didn't want to
You can
disturb.
just leave and come back. That'll be the easiest thing
Yeah.
to do. But just please keep your presentation open before you. Oh, she's left. Okay, no
Yeah.
problem.
So till then, maybe I think there are a couple of more questions. If you could take them.
Sure, please go ahead.
Abha ma'am is still here. She also had a few questions. Just 1 second, sir. I think a couple of questions were, yeah. Sir, there's Dr. Aarti Luthra from Dehradun. How to avoid IUGR in a lady with severe IUGR and oligo in a previous pregnancy? Is there any way of preventing that?
I think if I were not a gynecologist, I would give a short answer and say no. But I'm a gynecologist, so I'm going to give a long answer.
Yes.
It would pretty much depend on the risk factor over here and what the etiology of IUGR in the previous pregnancy was. For example, if the previous pregnancy she had preeclampsia, she had PIH, or she had any other systemic condition, then obviously the first thing you need to do is make sure that she's in the best of health before she gets pregnant again. And that could work to prevent IUGR. If, as I have already said, she has a tendency to preeclampsia and has high risk factors for preeclampsia, a good thing to do would be to start low dose aspirin for her at around 14 to 16 weeks. Although theoretically, in my view, you should actually be thinking of starting aspirin as early as 10 weeks. The theory behind giving aspirin really is that it facilitates the second wave of trophoblastic invasion. And we know from IVF that the second wave of trophoblastic invasion actually begins as early as 12 weeks. So rather than looking at the literature and saying start at 14 to 16 weeks, I would tend to start it at 10 to 12 weeks. Patients like this can also be offered more intensive monitoring. And when I say more intensive monitoring, I don't necessarily mean by Doppler. I would say serial assessments, serial symphysiofundal heights starting right from 24 weeks of gestation. And if there is less than a 10 centile growth, from the abdominal circumference or the estimated fetal weight, then it's a good idea to subject them to serial ultrasound Dopplers.
Absolutely.
The other important element of monitoring, which I think is probably not stressed enough, is daily fetal movement counts. And I think it's a good idea not only to tell the patient to be aware of fetal counts, but actually make a printout of the TDS fetal count and ask them to tick in that like homework. Occasionally, I even scold my patients saying that since they didn't do their homework, I'm going to give a remark to them. Because in high risk situations, I think that really makes a lot of difference. When I used to have some conversations with Prof. Arul Kumaran, he always used to say that if a fetus is moving, the fetus is not hypoxic. And that's the amount of importance that he attributes to fetal movements. So when I say intense surveillance, I don't necessarily mean serial Dopplers. I would also say that keeping an eye on fetal movement count is equally important. So any other drugs? Not really. I mean, we know that nothing seems to actually work very effectively in preventing, but if you would like, and if there is signs of either early IUGR or a difference in the Leica measurements, you could consider giving L-arginine. That's probably the only thing that would seem to work in these circumstances.
Yes, sir. Thank you, sir. So another question from Dr. Nimisha Agarwal from Delhi. She's asking, what are the guidelines for rescue steroids for FGR?
I'm not really sure what the rescue sort of refers to. I'm presuming that the rescue steroids means that the patient is at risk of a delivery and therefore you are going to give her a dose of steroids and then deliver her. And if that is the case, then by all means you should use it. The important thing while using steroids really is to make sure that you don't use repeated doses. I think one dose of steroid given at the time of imminent delivery is all that is needed. Giving repeated doses of steroids could actually be counterproductive. Rohan, I think Dr. Mitra Saxena madam is back. So if we could move on with the panel, that would be great.
Am I audible?
Yes, madam.
Okay. Okay, I'm very sorry, folks, but a very good evening. I bring you greetings from Rewari. The thing common between Dr. Jaideep Tank and myself is our Karam Bhumi is named the same, Ashwini. So I welcome all the panelists from all over India. I don't know how many of the 7 busy obstetricians are here. I could see 4 of them, but I think they will compensate. Then we have others also. So what we are going to be talking about is vaginal delivery, which is the very basic activity for continuity of human life through the natural processes. But this on any day. And as we can see, it has taken lots of tosses and turns in trying to make this journey good, bad, or even ugly sometimes. But let's keep our talk and panel to very, very basic questions when we are dealing with vaginal delivery. So I'll be taking you through all these if possible and if time permits. Second stage, as we all know, can be very dramatic. It's the journey of 10 centimeters for the baby, which can cost its life. And also for the obstetrician, it can cost us our lives when we can start challenging our own decisions. So to set the record straight, as also Dr. Tang said, that it is basically simplicity and consistency which ensure that labor and delivery is quite smooth because it is actually a normal process, natural process. But we always want the best, but we may not have the best. And we have to acknowledge that the labor in nulliparous is very different from how a multiparous behaves. A spontaneous labor as compared to induced, and a booked patient as compared to an unbooked, which is a googly. And sometimes we are confronted with patients coming right at the second stage. So what is most challenging is our own registered patient who starts her labor with us and goes into the second stage. So we know traditionally that there are 3 P's, but our practice says there are 3 more. It's the patient, her tolerance to labor, it's the obstetricians and how much she can bear the stress, and it is some interfering attendant. So now I will take the first question. I'll ask my friend, Dr. Poonam, to before we actually start delivering, do you think it is important to do a per abdomen examination even in the second stage? Dr. Poonam. Hello.
Good evening to everyone. Thanks to Dr. Jaydeep Tang, Dr. Parikshit, Dr. Rohan, Dr. Priyankar Roy, and Dr. Niharika Malhotra and Dr. Apurva for inviting me. And thank you, Dr. Mitra. It's a very important question. Role of abdominal examination is very important in second stage. If somebody has called me to the labor room in second stage and patient is not delivering, then first of all, I should start my examination from the abdomen just to assess how much is the size of the baby and shape of the abdomen. And localization of fetal heart is also important. That also tells where is the position of the head for, from the localization of fetal heart. That is also very important, especially in occipito-posterior. If there's a, then it's at a higher level. And next is there any change in the contour of uterus during contractions? These things are very important to note down. And because from abdominal examination, half the PV findings you can presume also. You can
So
assess
that's
from
very
abdomen.
nice, Dr. Poonam. My dear panelists, I will tell you one thing, that the time available is very little and we have to have, and thank you, Dr. Poonam, you have actually answered the question very nicely. And I will like that we go a little bit faster and our answers. So very rightly said that the clue for a pelvic can be very nicely obtained after doing a good per abdomen examination. And our labor room, I'm just taking you through my labor room in its preparedness. So Dr. Madhu, our madam from Kanpur, are you there, ma'am? Dr. Madhu? Okay, if Dr. Madhu is not there, I can see Dr. Prema or Dr. Sunil. Anybody can take this question, that in medical colleges, we were told to do a proper perineal cleansing and draping. But I see that in periphery, people are a little bit careless. What is your take on ensuring this part?
Madam, I would take that perineal cleansing is extremely important, and you have very properly shown how to use the different swabs and in which direction. But a simple principle which I am following and asking my staff to follow is from center to periphery. And
Very right.
when you go away, you don't come back, right? So from center to periphery and up to the at least minimally mid part of the thigh, you should clean it, and up to the umbilicus, it has to be properly clean. This is what I do it in my practice. So my principle of working for the perineal cleansing is the from center to periphery, and when you go out, don't come back.
That is very, very nice and one liner. And actually, I would like our panelists to come up with their practice. Fantastic. One line and it sums it all. And of course, we create a sterile field around the vaginal opening. So now, Dr. Prema, when we are going to be dealing in second stage, I would want you to set the house in order regarding the definition of second stage, the phases and the duration, because there is a lot of discrepancy. How long can you wait? Dr. Prema, are you there?
Yeah. Good
Okay.
evening.
Yes, ma'am.
I come from Mangalore, and the definition of second stage, as given to always, is from the complete starts from the complete dilatation of the cervix to complete delivery of the baby. So this part, there is two phases in that, where the baby's head, they descend, and then the delivery of the baby occurs. So
So would you like to say that there is a passive?
I don't know what your slide reads. You did say second stage and thing. Now, but if you were to involve the partogram, we would the duration of the second stage has been changed a bit now, so that it's 3 hours in a primi gravida, especially if they have been on epidural, or if they are not on epidural, it's 2 hours. And and in the multips, it is 1 hour, or if they are on epidural, 2 hours of is the duration.
So very right, Dr. Prema. What I would thank you for putting that in. What important thing is that in second stage, we have a passive stage, which is latent, even after dilatation of cervix. the presenting part or the head comes down up to the pelvic floor, and it is only after the active pushing when
Or
there
the
is
descent of the
descent.
head.
Yes,
Called the
and
descent
the
of the
total
head, which is seen in
duration,
the
that is
partogram.
why has
That's
been
seen in the partogram.
increased. Rightly said. So now we will take the case. Dr. Teja, where are you there with me? Ma'am? Dr. Tejavati? I could see her.
Dr.
Madam, can you hear me now?
Yeah, yes. Okay, ma'am. So now you're going to be delivering with this knowledge that what is the accepted duration of labor, etc., etc. So here is a primee. She's 39 years, 39 plus 4 weeks. Expected fetal weight is 2.9 kg. Pelvis is found to be adequate. And progress of labor was normal in the first stage. Now she's in second stage of labor since the last 1 hour. Maternal and fetal status is stable with good fetal heart sound. Your obstetrician on call. So now how will you assess this patient at this time, because she's been in labor for 1 hour, and when would you consider this to be prolonged? Is this prolonged, or would you, what is your comment?
No, since it's just 1 hour after the full dilatation and the maternal and the fetal condition, both of them are stable, I wouldn't really worry about, waiting and not interfering at all till there is distress either from the maternal side or the fetal heart variation. I would just wait and allow her to progress.
That's very nice. And what will you assess? I mean, you pelvic findings I've told you, but per abdomen, would you
as long as the descent of the fetal head is happening at least 1 to 2 centimeters per hour, and then she's quite stable, no fetal heart variation, I think I will just wait, assess for any caput or any molding, and if everything is smooth, I don't think I should worry at all.
Rightly said. So in primary, even if she has been dilated for an hour and she's not actively bearing down, we needn't worry. However,
another thing is contractions, madam. If she's having good contractions, I wouldn't really worry.
Yeah, and also that she's engaging and she's progressing. So now, what would you do once you are there? What would you ensure that in second stage? What should you next? What should you have?
One thing is about her contractions, whether she's having at least one contraction, once in 3 to 4 minutes, lasting for about, say, around 40 seconds. And if she's having good contractions and she's progressing, fine. But if there is no progress in the descent, and then, each contraction she keeps pushing, and I see no descent, and there is another, extension of another, say, half an hour to 1 hour, then I would probably, reassess and then see if I have to put in forceps or a vacuum. But I don't interfere at all.
Yeah.
There is
So
no fetal heart problem. Yeah, nothing.
This message of yours is the right one that I wanted, that when there is no distress and there is no problem, then we really have to just do masterly inactivity and watchful expectancy. So there are two things when you're going to do a pelvic examination. What are those two very important things which you like to see with respect to?
I would like to see the sagittal suture, whether whether it's in the right oblique. Most of the time, the normal, the occiput anterior position is left. So the sagittal suture will be in the right oblique diameter, and we'll see how much is the rotation. Because in in this position, there is about 45-degree rotation. So we'll see where is the sagittal suture and the station of the head, whether there is any caput or not.
Yeah.
And then reassess.
Okay, that's very nice. Now I will digress a little bit. I'll call in Dr. Meera if she's there. And if she's not there, anyone other person can just give an overview of your own practice. Do you do a pelvic assessment before labor antenatally, or do you leave it to active labor? And of course, in second stage, if you will always do the pelvic assessment. So I want the opinion of, is Dr. Meera there? I'm not able to, Dr. Meera is not there. So Dr. Sunil, can you come up with what is your practice? Antenatally, do you do a pelvic assessment?
No, madam, I am not doing a routine pelvic assessment unless and until patient goes into the labor. But one important point which I am checking
Yes.
in my practice, because most of us have a sonography machine in our consulting room. So I always, when patient is coming for a last minute checkup, I always check the BPD. If BPD is less than 93 or 95 millimeter, then I can assume that the progress will be smoother, right? So that is what something it is in our my mind before assessment of the pelvis, because cephalic this thing is also very important. So,
So,
but I don't do a pelvic assessment antenatally.
so that is very good thing, and actually you've got yourself into trouble because those who have an ultrasound machine, they would you also tell them that please always look at the lie and confirm it and the weight also. I mean, if we have the ultrasound machine with us, then do you think
Yeah,
it will be
yeah,
very
yes, ma'am.
helpful to
Yes,
us?
ma'am. I doing practice in a city area, so my patients are very well been examined antenatally. Amount of Leica, color Doppler, all everything has been assessed before patient goes into the labor.
That's very good.
Madam,
So
I
that
would
is
just like to
I
add,
would like,
like to add
go
that
ahead.
if everything is okay, I mean the height and the average size baby and the head has got engaged, I don't think I will do an antenatal assessment. If there is any doubt, if she's a little short and if I feel the baby is big, definitely maybe in the last, after she completes 39 weeks, then I would just to make sure that her pelvis is okay, I would like to assess her. Otherwise, usually when they come in active labor, if everything is okay, I would assess her in active labor.
okay. So that is very right. The final take
I
home
would,
is, yeah.
I would do a pelvic assessment antenatally.
At what
Because,
gestational
I
age?
mean, I would do a pelvic examination, which includes a lot of other information. And I feel confident, and we can talk with the patient, with the mother, like when she's likely to deliver, if the baby is adequate. She has a reason, if the pelvis is adequate for that baby, if it's in position, and when she's likely to deliver, all this information I can give her. So I
Okay.
would prefer after 38 weeks to do an
So a
pelvic,
practical question, as a keen obstetrician, we were taught that we should know the length of our fingers. This is the length of my index finger. I'm sure that every obstetrician would make sure that their fingers, their length of the markings which the nature has given are well marked. I hope all my panelists can say yes in
Yes, yeah.
unison.
This is
Yeah,
Yes,
so that the
Yes,
it's
ma'am.
audience
important.
and the
Yes.
youngsters, they should learn that all of us need to know the length of our fingers. Now, Dr. Teja or Dr. Prema, this patient who you were called, and she's in second stage, and we have assessed that all is fine, but the resident or the nurse on duty tells you that the fetal heart is dipping to 100 beats per minute during contraction. So now, please tell me, even if it is, if you're practicing with CTG, would you like to do a intrapartum CTG and assess and wait, or what would you like to do?
The first thing I would like to do is, do a PV and see if the head is coming down.
You've done that already.
Yeah, done.
Everything was
PV,
fine. It's the
because
same
sometimes
patient.
compression of the head, they can be fetal bradycardia.
We have to, we have to time we're seeing a D cell. We have to time the D cell, whether it is because of the head compression. Yeah, if it's early or late deceleration, or this thing, how deep is the deceleration, at how low it goes in, and it's okay to, it's reassuring. I don't do,
Hello?
and for how long the D cells are going to continue. If they're, and if there's meconium also in the Leica.
So in this patient, there wasn't any meconium, and only the heart rate was dipping with the contraction, and the
it was
CTG
recovering.
was not very scary.
Yeah.
So
we would like to know whether it is, the heartbeat would come up to the baseline
Yeah.
after the contraction. So
Would
that
you
also is
suggest-
important.
Would you suggest something to
But
supplement?
IV would start oxygen, IV fluid, stop the oxytocin, monitor the contractions or not. Like
Patient is already getting good uterine contractions, madam. Would you like to increase the contractions? What is the opinion?
Stop the oxytocin actually.
Sorry?
I would stop the oxytocin if that is, because in
No,
second stage
she's getting good
then-
contractions. It's not, too much tachysystole nahi hai. Would you?
Depending on which category, madam, maybe we could assess whether
So
it
it
is
is
1, 2 or 3.
basically a reassuring one. It's not the ominous one. Now, I will ask somebody else to step in. Dr. Neelam, if at this time you come into the labor room and you find, because the head is visible and there is some dipping, and you find the residents are trying to achieve delivery with the fundal pressure, what would be your take, Dr. Neelam or Dr. Sunil or?
Dr. Mitra, for inviting me for this panel. Yes, if the delivery is not occurring, we can give 1 or 2 gentle fundal pressure, but it should not be very strong. But the only disadvantage is we should give proper support at the perineum, because sometimes with the fundal pressure there is increased chances of cervical tear as well as perineal tear. So gentle fundal pressure we can give in such patient to deliver the baby.
So I know
in
that I have opened a hornet's nest, and I don't know what is the impression about and what's the practice of my panelists, but yes, this is something which almost all obstetricians are using, and there are papers in the Cochrane library.
Cochrane 17, yes.
Only thing is that this is a little bit controversial, because if caution is not exercised, as Dr. Neelam has rightly said, we may land into bigger trouble if there is 3rd degree or 4th degree perineal tear. So
another thing is, madam, it is not found to be, found to reduce the second stage or, bring down the operative delivery. So that is what the Cochrane 2018 review says.
Yeah. Thank you, Dr. Teja. But yes, what I wanted to just accept publicly is that if and when we are going to use in a dire situation, it has to be very controlled, very gentle, and make sure that we give adequate perineal support.
Madam, I want to highlight one thing.
Please do, sir.
Many times when residents are doing pervaginal examination, a repeated pervaginal examination and touching to the head can also lead to a bradycardia, fetal bradycardia. So that also we have to rule out. A repeated pervaginal examination and touching to the head, and little bit cautious about the partial compression of the umbilical cord.
Okay, so yeah, we sometimes see that the baby is descending and then going back again, and with contraction comes down, there's bradycardia. Then when there's no pain, it goes back again. And when the baby delivers, there is 1 or 2 loops of cord. But because there's no gross hypoxia of the fetus, so normally there isn't much damage. Okay, now Dr. Poonam, Dr. Madhu has joined or not?
Yes.
Dr. Madhu, ma'am? Okay, so Dr. Poonam.
Dr. Poonam, I'm ready.
This is the same primary. She's not yet delivered. Please remember. And she is not in any distress as such, but there is a small caput of 2 into 2 centimeters with grade 2 holding. There is little bit short of rotation, and she is right now 1.5 hours into the second stage. Will you still do masterly inactivity, or with your practice, what would you like to do for her? And the pelvis.
First of all, fetal heart is important in this case.
So it is nice. It's okay.
Yeah. If fetal heart is normal and cervix is fully dilated and vertex is at +2, where is the station?
It is +1, not +2.
+1, not +2. Yes.
She is progressing.
And grade 2 molding means it's a reducible molding and sutures. So one can try Ventouse also in this case.
So, ma'am, Dr. Poonam, I'm not asking what can one do. I'm saying what Dr. Poonam would do for this primey. Would you still wait? Can you wait? Or would you do 1-2s?
Yeah, if fetal heart is normal, we can wait also for spontaneous rotation
So
of the head. Yes.
Dr. Poonam wants to wait. That's very good. And
Yes.
whilst you are waiting, will you okay, sorry. So you said about ventos. One question, small question, that if there is caput, do we still allow ventos? What is the practice of other panelists and Dr. Poonam? With a small caput, do you put ventos?
Then
no
it's safe
problem to
now.
put the
Otherwise, with big caput,
with that, there's no
ventos is
problem.
not
The
safe.
small cap. We create a shape.
And even head station is also very important for that decision.
Okay, so in case you were to use an instrumental delivery in this case, what would be your instrument of choice? It is short of rotation.
Yes.
Ventus.
If I think she's not progressing and head is not coming down and there's no rotation and caput is increasing, so better I will take this patient for cesarean section.
Okay, that is fair enough, Dr. Poonam, because none of us want to be burdened with a moribund baby. That's a very valid decision.
And timely decision is very important. Even if you take late and there's a more morbidity, and even cesarean also becomes very difficult.
Very right. Very right. Now, I would like to ask you that there are sometimes a condition. See, when the baby was at a higher station, we waited for the passive descent of the baby when the mother will start pushing. So, Dr. Prema, could be there some conditions where you would want the patient to start bearing down? Dr. Prema? Sometimes we know that the pelvis is good, the baby is not so big, and we don't want to wait for the patient to get the active pushing, and we want the patient to deliver. Would you like to tell which conditions this could be?
No. If you're worried about the baby's fetal heart, or is like there are dipping and we want the baby out, like it's a bit precious pregnancy, and even we are getting perturbed with the fetal heart rate, then maybe we would ask her to push and we can and bring the head down, or we would put instrumental. But otherwise we will let things stay. I'm sorry, I will not be able to know exactly what you wanted. Yeah.
Okay, so actually, basically, I just wanted to say, which you have partly
At least
answered
2
very-
hours if there is no descent, madam. At least 2 hours if there is no descent.
But here she said it's just even in the latent phase.
So there may be conditions where we want to expedite delivery earlier. For example, if a patient has cardiac disease and the baby is small, severe anemia, baby is small, then we don't want her to go into prolonged second stage. Or when we know that the baby can come out and we expedite the delivery. Now, Dr. Teja, this is a very, very common situation in a primary especially, that there are some reasons for prolongation of second stage. Will you please enumerate what are those reasons?
One is maybe not favorable position.
Yes,
fetus not being in favorable position, for example, occipito-posterior, or patient not having good enough pains, or the shape and size. Maybe she is not having the, the gynecoid pelvis where all of us, prefer that kind of a pelvis. Maybe she has android or anthropoid pelvis. So these are the three conditions where you expect patient to, have a prolonged labor.
Yeah, so very right. The most often and very importantly taught 3 Ps, and of course a woman who is exhausted and not ready to bear down or very fearful. So here we are going to be very judicious in how we proceed with such a patient. Right. So now is Dr. Meera there? Dr. Meera, I think she informed that she was joining.
Dr. Meera is stuck in an emergency.
Okay.
One of her relatives.
So never mind. Dr. Sunil can take this question or anyone else. Dr. Neelam, that does maternal position in second stage have any effect on the duration, and what is the best posture? Like, is it
Yeah.
lithotomy, dorsal lithotomy? What is your practice, ma'am?
Normal is the dorsal lithotomy, but for timing, we can put the patient in the left lateral position for better blood flow. And one more thing, when the patient is given epidural anesthesia, in those cases also, the second stage, patient is not able to bear down in the second stage. So,
yeah, very right. So it will be prolonged. Yeah.
yeah. And patient should be in the dorsal lithotomy, but in between we can put her in the left lateral position for the better oxygenation of the baby.
So, and
what we, I would just like to add, what we do is, madam, dorsal position, and we elevate the head end,
yeah,
slightly,
so upright.
that
You want to say the
upright they will
yeah, upright, yeah.
So that gravity will help us in the effective transmission of the pushing efforts of the mother. So
And
anybody would like to tell us
change
about
the intermittent position to make her comfortable. So we can put her in a squatting position for a while, and then again in a dorsal lithotomy position with both the legs, knees bend down to the up to bend, taking to the tummy. So different position can help and making her comfortable will help coming down the baby, pushing down the baby.
Thank you very much. Now, I just wanted any one of the panelists to answer. We were taught that we should do Valsalva. We should ask the patient to push against a closed glottis, which is directed pushing. What is now recommended? Should we do the same or spontaneous pushing is better?
No, we should not do this Valsalva.
Spontaneous is much better, madam. Spontaneous
At the time of contraction, because it reduces the oxygen. Mother and the baby. So we should not do this. Let her come out spontaneously.
So that is a very right take-home message, that we should advise the patient and we should allow her to be in upright postures and do spontaneous pushing, because when we ask her to push against closed glottis, there is more chance of decrease in the oxygen in the intervallar spaces.
Yes.
So that's it. Good. Now let's go to the second case which Dr. Sunil Shah is going to manage for us. This is a 28-year-old second gravida, and she has had an uncomplicated pregnancy, receiving oxytocin for augmentation. Second stage is for 50 minutes. On internal examination, Dr. Sunil, you find that it is right occipital posterior. What would you do?
Occipital posterior.
Yeah.
So, young lady with a average size baby.
Yeah.
Right, and 50 minutes has passed for this thing, and patient is having, the baby is in occipital posterior position. So I will go ahead with the wait and watch policy, because nothing is abnormal. Occipital posterior position, we should wait for time. FHS has to be observed, contraction has to be seen, and watch for the progress of the labor. So we know that the occipital posterior with average size baby and good efforts by the mother and adequate pelvis, the baby will deliver normally.
Very true. I think you're a very successful obstetrician, because you will deliver all the occipital posterior positions also, provided there is no contraindication. So now I will ask Dr. Poonam to quickly tell us about how does she manage to support the perineum, because now we are going to be talking about the perineum, which we have to protect from trauma. So it is a very basic thing, but Dr. Poonam.
Yeah, when the patient is delivering, perineal support is very important, and which we are following since so many years. Just take a pad and tell the assistant to support the perineum when the baby is coming out. That's very important to avoid perineal injuries and lateral injuries.
Okay,
so
we can use the modified Regents manual.
Are you using it, Dr. Teja? Are you using?
I mean, sometimes yes, not always, but we try to, put a little pressure and see that flexion is maintained for a controlled delivery of the head.
So basically, we keep one hand over the occiput to keep the flexion hinge it behind symphysis. And when we do the regions, actually we are pushing the chin up, so that we are actually helping in the extension of the head, and it is all controlled. Thank you so much. And all of us as obstetricians need to respect the perineum. So I'm not going to be talking about why, when, how we do the episiotomy. I'm going to be talking about some finer minutities of episiotomy. If Dr. Madhu has joined, or otherwise somebody else will like to take this question, how do they deal with extensions and episiotomies, and what is the best suture, what is the best technique? So we have to be a little quick because I want to do more, two more cases also. So
it depends, madam. Whatever we use, usually 20 or 30 chromic catgut, and suture in 3 layers. We start beyond the apex, and first the vaginal mucosa continuous, and muzzle is interrupted, and skin again is we put a mattress suture.
okay, I would like to ask the views of other panelists. Are you all using chromic catgut?
No,
we are using Vicryl Rapid.
I use Vicryl
Vicryl Rapid,
okay,
because it gets absorbed easily.
Vicryl also, and this continuous subcuticular, because less knots in the perineum, so there will be less pain. So we do subcuticular by Vicryl 20, or this Vicryl Rapid nowadays coming. It is very good, and you do subcuticular, that gives a very good result and less pain also.
Okay, anybody wants to add something to stitching up the extensions in the episiotomy, which go deep into the vagina or onto the perineum? You have a wound of the episiotomy and you have another laceration. How will you go about it? What are the things you should keep in mind? Whoever is going to take it, please.
Yeah,
you should make sure
one person, ma'am.
Hemostasis as well as proper approximation of the episiotomy wound. If there is an sphincter laceration, we must stitch it properly to approximate the sphincter, and we must do proper hemostasis. This is very important at the time of stitching the episiotomy. Otherwise, it gives way and there is a gap.
So, make sure there is no dead space, and all the bleeding points need to be, properly.
Yeah.
Closed.
So if there is any arterial bleed, which will be from the pudendal artery or from the vaginal artery, that must be ligated properly. If it's a venous, it may stop with your tamponade. So that is very nice. And what we have to do is look at the anatomy of the muscles which are torn if they are avulsed. And if it's a deep episiotomy, please do not stitch all the mucosa. After halfway through, approximate the muscles and then come up to the fourchette. So that is very nice. And I think as an obstetrician, this is one of my very important lessons that I've learned, and that is be patient and do it the best the first time. So now quickly we will go, Dr. Prema. Please enumerate, because everybody is doing AMTSL, just salient points of active management, because we've
active
been
management of third stage of labor is very important, should be practiced in all, and it is where there is there were 2 parts to it. You have to give an oxytocin within 1 minute of the delivery of the baby, usually after the anterior shoulder and all the baby is delivered, and then wait for signs of placental separation and deliver the placenta by controlled contraction. What is not usually advised is the uterine fundal massage. You want me to take the next thing? The delayed
Anybody would like to add something to that? So basically,
the oxytocin
one is
10 units
oxytocin.
given IL.
In some patients, we do use tranexamic acid injections.
No, that is not okay. Yeah. Anything else is an additional. But
delayed clamping of the cord in cases of premature baby.
Okay.
Clamping in RH negative.
Okay, ma'am. So what I want is everybody, I now want very clear messages to the people who are attending. Has everybody started doing AMTSL? Because really it decreases the chances of PPH remarkably. Second thing is everybody putting the baby which is crying on the mother's abdomen? Because we have found that this causes in very improved bonding between the baby and mother and establishment of lactation. And also a word about the delayed clamping of the cord. Dr. Teja, can you please take that and tell why it is important, the delayed clamping of the cord?
The delayed cord clamping allows extra amount of blood, almost 80 to 100 ml extra blood to the baby, so that the hemoglobin is better, and the iron stores are good enough when you examine at 3 or 6 months after the baby is born. So that is really important.
Yeah. So what was important also is that it's not just the term babies, but also in the preterm babies.
Preterm also, it applies even to preterm babies. Only in RH negative and in deeply asphyxiated, where you need to attend to the baby. In only those two conditions, we need to cut the cord a little early. Otherwise, universal following of delayed cord clamping.
So this is a very clear-cut message from my eminent panelists that everybody, if you're not doing this, please make that little change. Please give the advantage of more blood to your babies. So
One
now,
thing, Dr. Mitra,
yeah,
like in our hospital, we are following this delayed clamping in preterm infants and this term pregnancies also.
Yeah.
But latest guideline, they have said that delayed clamping normally duration is 1 to 3 minutes. But now they say that you can wait till the expulsion of separation of placenta completely, and you can keep on.
Yeah,
waiting.
Government of India says
Also,
that
yes.
you wait for the placenta to come out. Till then you can do it.
And then also, yes.
In any case, from immediate clamping to delayed clamping is a paradigm shift, and I'm glad and I'm sure that every obstetrician in India will start doing uniformly. Now, very important stage, that is the fourth stage and the golden hour. So, who hasn't yet taken a question for a long time? Dr. Sunil? Dr. Sunil is there?
Madam, what is the question?
So 1 hour after the delivery, do you think this is very important time, and why is it important?
It is, madam, extremely important because many a time after placenta there is no PPH immediately, and you have sutured episiotomy and you have put a mop or a pad inside the vagina, and then after 5 or 10 minutes or 15 minutes you are relaxed and there is a lot of collection of the blood inside the uterus. And secondary, we cannot tell it secondary PPH, but PPH starts. So 1 hour post delivery, that's a golden hour, and no obstetrician should bring that miss that golden hour, and you should not allow patient to transfer from labor room to the room for that 1 hour.
Thank you so much. That is so important. And I am in a small city. I am by myself. So I have made it my practice that after 1 hour, within an hour, my nurses do a single finger gentle PR and another PV with one finger to see that there is no hematoma, because hematoma is something that we are all very much worried. And of course, PPH. Thank you so much. So now,
Madam, not only that, but if you find that there is a PPH in this 1 hour, then it is very easy to control. Then if you see it after 1.5 hours, then the problem is so grave that very difficult to control. So any PPH within 1 hour is very easily tackled. Then problem that we diagnose after 1.5 hours.
Almost that is the most
in the 1
important
hour,
message.
the monitoring should be there, being done during that 1 hour. Not the end of the 1 hour that is important.
Yeah,
That whole 1 hour, the mother should be monitored.
Yeah. And the perineum
should be taken every 15 minutes till 1 hour, then every 30 minutes till second hour, and then we should leave the patient, because everything happened in the first hour only.
Idea is, which Dr. Sunil has and all the panelists have mentioned, that please do not forget this very, very important monitoring of the patient after delivery. What happens is that the mother, the family, and the doctor all are very relaxed, and then we miss the bus. Thank you so much.
Madam, what about the intermittent, uterine massage by the patient herself, which...
No, I'm
intermittent,
sorry,
not-
I haven't reviewed that. I will not be able to comment on that. But if you
Okay.
have any idea, please do share it with us, Dr. Teja.
No, not the continuous one, of course we don't, but then they say intermittent massaging, by patient herself will, bring down the...
Personally, in my practice, ma'am, immediately after delivery, after the baby is on the mother's abdomen and the baby is crying, we try the breast crawl and we try and establish lactation in the first 1 hour, which is very helpful in causing the uterus to contract. So now I have 2 more important emergencies to tackle in my labor room. So all of you, my panelists, please get ready. We are going to face, because I'm not going to talk about second stage cesarean. I'm sure Dr. Tank will have another session for that. And operative vaginal delivery, I haven't touched on it because these things need more detailed discussion. Well, Dr. Neelam, you were delivering this second gravida, and when she ruptured her membranes, a loop of cord came. What will you do?
Immediately I will try to push up the cord, and I see the position. If the position of the head is favorable, we'll put the vacuum and take out the baby immediately. If the position is not favorable, if she is having an transverse arrest or something like that, then we should do immediately shift to cesarean section.
Any panelists would like to add or delete something?
Like in this...
We'll have to change, put the position of the
position, yes.
Yeah, pregnant women, put the foot end a little high so that the cord, recedes a little, and then arrange for an emergency section. And depends what is the dilatation of the SN also.
It's fully dilated. I said it was the second patient which Dr. Sunil was delivering, and she ruptured the membranes and the cord came. Okay.
The tendency is to put the cord back, but it will never stay inside. The tendency is to put, because it wriggles and comes out. And we waste our time putting, and even handling the cord itself will cause constriction.
Very true.
And immediate crack.
After deliver, if you can.
Thank you very much for bringing out that point, that we should not try to replace the cord. Only thing is we should try to decrease the pressure on the cord, which is done by the change in the posture of the patient. And if we know that the pelvis is good, baby is small, we can pull out the baby in one pull of the vacuum. We should, immediate delivery is the answer. Thank you so much for bringing up this. And now we know it's a true race against time, and we have to deliver the baby as fast as possible. Now, Dr. Sunil, or I think every time I'm putting the stress on him, that's because 2 of my obstetricians are not here. So here is a patient, she's second gravida, she goes into spontaneous labor. She had a first stage of 13 hours and 15 minutes of full dilatation and bearing down, the head delivered. But this is how the baby looks. So I'm sure everybody's pulses would be racing right now. So who will come and deliver this baby for me?
Shoulder dystocia.
Yes, Dr. Teja, you're very right.
Yeah.
Our nightmares. So how would you deliver this?
We have to call for help now, because we can't do it alone. And we have to, whatever we have done in our drills, that's going to come out now. So we'll put the McRoberts technique by folding her thighs on the abdomen, and suprapubic pressure is given, and maybe you can extend the episiotomy, and axial traction of the head is done at the neck, and we would try to deliver and pray that it delivers with just the McRoberts.
Yeah, that is
We'll
what
have
I
to call for help, madam. Help is
she said that. Dr. Prema, I am extremely, extremely happy, because this is exactly what I wanted you to answer, because I didn't want it as a theory answer that these are the maneuvers, because the message to our audience is that if you're stuck in this position, don't panic, get help, as you've rightly said. And do these maneuvers. Now, can I just go back and somebody would elaborate that when shoulder dystocia occurs, what's the thing that has gone wrong?
Mitra ma'am, I'm really sorry to disturb, but we've got only 10 minutes left for the
Oh,
panel.
no, I'm going to be finishing. I'm almost at the fag end. I'm quite happy with that. My panelists are very good. Okay, so I will just summarize it. Basically, we have to remember.
It's either stuck below the symphysis or behind at the sacrum.
Okay, yes, ma'am.
Posterior and anterior shoulders have been stuck. They are not yet engaged.
No, I didn't get your question, madam.
I wanted to ask that when we are having shoulder dystocia, a true one, the shoulders are actually in AP in the inlet, which is the smallest. So when we are doing these procedures, that is the macroberts and the suprapubic pressure, we are just trying to dislodge the shoulder away from the midline so that it engages in the oblique diameter. That is just to remember, because normally we have to adduct the shoulders and dislodge it away from the midline. Thank you so much. And Dr. Sunil, when you are stuck with a shoulder dystocia, what all would you document, and what complications can happen to the baby and mother? This is just to complete the list of shoulder dystocia.
Can I take this?
Yeah, please do. Anybody.
Now, the first thing is we have to, document the time of the arrest of the fetal. How long, as soon as the head has come out, what all maneuvers did we start, and what time, which shoulder was beneath the, whether it was the anterior, right, or the left, and how long did you take to deliver the shoulder? What was the state of the baby? Did it cry? Apgar score? And then was there any PPH or any laceration or perineal tears? And then what time? Apgar score. I think this much you need to document. Yeah.
You need to take the cord blood, and cord blood has to be referred.
Okay. So thank you so much, all my panelists. You all are very, very competent obstetricians. Now, I would like you all to give one message each so that we finish in time, and I still have 6 minutes. So one one message for the audience from all of my panelists.
One is, Dr. Mitra, good communication is very important, and evidence-based practice. This is my message.
Very good. So the next panelist, please.
I would like to say that labor is a spontaneous, natural process. Don't interfere unless indicated, whether it is maternal or fetal distress.
Thank you so much. And Dr. Prema?
Well, labor is the agony and ecstasy of the mother. Let her enjoy it. And we have to make sure, and the other thing to know that is, it's all individual. We have been doing so many deliveries, yet I cannot be confident that the next mother I'm going to bring her home safely. Each individual, and we have to take decisions for her in the end, despite all the theory.
Thank you. And Dr. Neelam? Dr. Neelam, ma'am? Dr. Sunil?
Because nowadays there's a time of consumer forum, so we have to be very much particular about the fetal monitoring and the lie all the time, and telling the attendants about the condition of the patient. And we should not take much risk, because even a smallest risk or fetal asphyxia, or like in wild shoulder dystocia, there may be arch palsy, so there will be a lot of problems. So we should not take much risk in doing normal delivery.
Okay, and Dr. Sunil Shah?
Be patient, follow the partogram, and always keep neonatologist in your labor room at the time of the delivery.
That is always there.
Okay, I think Dr. Sunil Shah and me, we are far apart in Ahmedabad and Rewari, but there are a lot of things which are very much common. So it is that my only lesson is that we should start preparation antenatally, utmost vigilance in labor, and readiness for eventualities. But I would really share with you, friends, never get stuck with shoulder dystocia. I've got stuck 2 times, and I always keep that in my mind. So thanks to everyone. Every time we get a crying, uninjured baby and a satisfied mother, the obstetrician in us is immensely thrilled. But if things go wrong, which happens unfortunately, we are left questioning our own competence and decision making. So friends, let's make practice of obstetrics safe and mindful. Thank you everybody for your patient cooperation, and I hope you all enjoyed this panel as much as I enjoyed
Thank you, Dr.
moderating it.
Mitra. Thank you to all.
Thank you, madam.
Thank you very
Thank you,
much,
madam. And I would
Dr.
like to
Jaideep
thank
Chand,
Dr.
and congratulations for the wonderful program. Thank you, Mitra madam, and thank you all my co-panelists. Thank you very much.
I would like to thank Dr. Jaideep and Dr. Parishit and Dr.
Thank you,
Rohan and
Dr.
all the young brigades for this.
Thank you, the
Thank you,
moderator
Dr.
and
Jaideep.
the panelists for successfully conducting the delivery. I'm sure
Time,
there will
Dr.
not be
Jaideep.
any pain after this delivery.
I think you can take a picture because my video was off all the time. I never realized. I'm so sorry that I was
We'll
late
take picture.
logging in.
Rohan, are there any questions? Thank you, all the Dr. Mitra, wonderful panel, really. Very well prepared, excellent questions, very practical suggestions from all the panelists, Poonam Madam, Neelam Madam, Dr. Prema, Sunil, and Dr. Tejavati. We missed two of our panelists. They were both stuck in obstetric emergencies. So I hope they also had safe labor and deliveries like
Yes.
we did, in this wonderful panel. Rohan, if there are any questions, we can take them. Otherwise, we can move on to the vote of thanks.
There are a few questions for the panelists. Dr. Shilpa Agarwal from Mumbai says, will BPD change with engagement?
No,
No.
it doesn't.
Okay.
BPD doesn't change.
BPD,
Actually, can I add something, Dr. Jaideep Tank?
Yes,
I was unable to introduce a lot of things in my panel, but yes, I would like to inform, just like Dr. Sunil Shah, he has an ultrasound in his practice. So we all can review the ICO guidelines about assessing the position of a head intrapartum. And I didn't divulge there because I wanted to do it more practical. But yes, it can be a learning point for us, because especially in cases where we have to do operative vaginal delivery and we are not sure, because mind you, with that caput and molding, it's not
Very
easy
difficult.
to make out the exact position. For me, I try and learn that after I've done the PV and after the baby is delivered, I look at the caput and try and assess whether I was right or wrong. So I think it's a self-learning process. So thank
Madam,
you,
I was
Dr.
not
Jaideep
a
Tank. You
panelist,
gave me a wonderful opportunity.
I just want to add that an important thing I look at is the position of the fetal heart.
Yeah, I do that. I
That
do
denotes
that a
the
lot.
anterior shoulder.
Yes.
Or in some instances, the posterior shoulder. So
Yeah.
if there is a lot of caput and molding and I can't make out the position of the occiput, I look at the position of the fetal heart on the abdomen. And if the position is in the midline, I know that it's either occipito anterior or occipito posterior.
Yeah.
In either case, I'll be able to apply a forceps and deliver. So just an addition.
So that is why,
Very
if you
good practical
remember
point,
the
Dr.
initial
Jaideep. Very
slides,
good practical
I had put all the heart rates, where is the heart located, because a lot of the clues we get by per abdomen examination. So I'm so glad that all of us are on the same page.
There's just one more question from Dr. Alka Seth from Jhansi. She's asking, what precautions can be taken to avoid vulval hematoma while stitching episiotomy?
Dr. Tank, you will take, or I can take that?
No, madam, please. I just...
Okay, so my personal take is, before I start the episiotomy, as I had shown you pictures from my labor room, I have very good lights and I have a crash cart there itself. So I never hesitate in looking at the whole of the vagina, look at all the lacerations, everything before I start stitching the episiotomy. And my single thing is, whenever there is a bleeder, look at the type, how it is welling up. We are able to make it an arterial bleed or a venous bleed. I use artery forceps to hold the vessels. I take time to ligate all the vessels, and I'm very patient. Another thing which I was not able to add on is that I always cut one extra glove. I make 5 finger gloves for myself. And whenever I take the highest stitch, I make sure that the apex of the vagina, I only take the vagina. I don't take deeper, because there is a tendency to take a very deep stitch thinking as if it's going to stop It's not like that. That is the time you are going to make an unknown RVF, because you've gone through the vagina and the rectum. Never forget your anatomy. So one thing is that take the highest point at apex, but in the vagina, only keep the vagina there. And then I don't stitch the whole vagina mucosa. I look at the depth. If there is a vessel, I am very, very careful that I have ligated the vessels. I approximate the muscles independently, individually. I don't do a continuous suture. And I always check my sutures because I have 5. I keep doing PR in between. And when I'm slow, I'm quite sure I've not made a hematoma. When you stitch quickly and run away, that's the time there you've left a vessel. If you're very slow, there is very little chance that you will have a hematoma later. That's my learning. Dr. Tank, I would like you to add your learning also.
No, ma'am, I think you have put it very well. I would like to ask the other panelists if they would like to think. I have just one thing to add. The thing I have found most useful is to look at the hemostasis layer by layer. That means I suture the vagina, I check the hemostasis. Then I suture the subcute and the muscle. I check the hemostasis. I suture the skin and then I check the hemostasis rather than suturing everything and then checking hemostasis. Occasionally we've had, so if you check the hemostasis after finishing every layer, it's unlikely that you'll miss a bleeder. But to tell you the truth, honestly, at some point in time, all of us will get hematomas.
Yeah, we've had.
Of how careful we are. So the formation of a hematoma shouldn't really be an indictment of how well we have sutured an episiotomy. It is when you get repeatedly or more often you get hematomas, that's when you really start worrying about your technique. If you get a hematoma, say for example, you're doing 50 deliveries a month and you get a hematoma once a year, I think that is, I don't know, that's pretty much expected. What is unacceptable is ignoring the symptoms of a patient who has hematoma, the primary of which is pain. So when a patient complains of pain after a delivery, you have to take it seriously and go and actually look at the stitches and do a PV or a PR. I think that's really the most important thing I can say, because hematomas, irrespective of how careful you are, they will occur.
And they will occur in the most VIP patient of yours. And they will remind you in the OPD, "Main doctor sahab, aapki hematoma wali patient." And they will be very faithful to you also. But they, some of your shoulder dystocias and hematomas stay in your mind.
Can I ask?
I would like to just share.
She's been very. Madam, do you have any thoughts on this?
Dr. Jaideep, I would like to just share, some maybe about 20 years back, I had a patient with a short perineum.
Yeah.
And then I took a stitch and the patient had RVF. From then, I always assess the length and then take superficial stitches.
One more thing, after delivery, we must do PR examination just to check everything is okay. That is important. Last.
That's very important. Yes.
Thank you, Dr. Jaideep, for bringing me in. Well, as you rightly said, layer by layer, that's very important. Like once you stitch one layer, you wait, see the hemostasis and then proceed further. That is a very good way. And that is what we are teaching our residents, our juniors, that they should go that way. And hematoma, I think, as Dr. Mitra has rightly said, it usually happens with a very VIP patient. And sometimes it tend to recur also. In spite of all precautions, if there is a bad tear you have done, the senior most person has done, and again the patient, she comes up with a swelling. Sometimes we have seen that also. So there may be some coagulation problem or something like that, so that it comes up. So I think putting in a drain, I think that is also an important thing. You should put a drain while you are stitching the second time. Always put in a drain when you are doing a vaginal hematoma.
Yeah, vulval hematoma, yes.
And, we should put a drain. And doing a PR after completion of the surgery, I think that is very important so that we do not get into an RVF.
Yeah.
And sometimes when there's too much bleeding in the episiotomy, I do give anesthesia and I fulgurate all the bicotry. It becomes very easy and we perfectly done. The too many bleeders and bleeding profusely. In those cases, so many bleeders you cannot tie. Then you just do cautery. That gives a very good result. Immediately everything stops and you do nicely episiotomy stitching.
I think Rohan is looking at me that we are out of time.
Yes.
But Rohan, I'd just like to add one more thing, that if you get a hematoma and you have to suture it, my advice always is to reopen the entire episiotomy.
Yes.
I have seen a tendency where people actually open only the hematoma part
No,
and
no.
resuture that. That's really not a good idea. You should reopen the entire episiotomy and resuture the entire thing, paying special attention to the area of the hematoma. I think that's a very important point.
You'll have to evacuate it nicely.
And it should be done in the operation theater.
Absolutely.
Yeah, with anesthesia.
Very hard. It should be in the OT, not in labor room.
Not
Yes.
in the liver. I think that's very. I've actually been called twice by people who have done that. They had a hematoma, so they just opened the skin, drained it, resutured it. No, if you get one hematoma, reopen the whole thing. And if you're going to do it quickly enough, you'll find that you don't really have that much edema and friability. The problem comes when you detect the hematoma late.
Late.
The hematoma has been there for 6-8 hours, and then when you're called, at that time the tissue is really bad. But if you detect it in 1 or 2 hours, you'll find that it's quite easy, to resuture that area.
1 or 2 times I have drained the hematoma when it is delayed. I have drained the hematoma, I have ligated the vessels, and I have not closed the whole of episiotomy.
Yes.
Because you allow a little bit of drainage and it comes together, give good antibiotics, good painkillers. And really, my personal message is that all of us obstetricians should really realize that the perineal body is very small. If we mess it up in the first time, we give very little chance to the woman to have a dignified and respectful perineum for her future life. So I think we all should respect that.
Thank you again to all the panelists. That was a wonderful discussion. Dr. Sunil Shah just messaged me he had to leave because he had another Foxy meeting. So thank you again, Dr. Poonam, Dr. Prema, Neelam Madam, Tejavati, Mitra Madam, and of course, thank you, Dr. Abharani Sinha, for not only a wonderful presentation, but also staying back for the entire panel. I am very happy to share that, and always look upon this as an index of the success of the panel discussion. So I'm happy to say that there are many more people who have joined towards the end of the session rather than the beginning of the session. And right now there are 4,585 people logged in for this webinar. So thank you very much, everybody again. And Rohan, if you could please go ahead and continue.
Okay. Thank you, sir. Thank you so much.
Thank you.
Thanks to everyone.
Thank you. Thank you.
Thank you so much, madam. I just want to give the vote of thanks. Before I start with the vote of thanks, I just like to tell everyone that we have a break next week and we'll be restarting the O2S webinar series from the 3rd of March. I'd like to start by thanking Dr. Jaideep Dang and Dr. Parikshit Dang, the convener and the co-conveners, for giving me the opportunity to be the moderator for this program. I want to thank our chief guest, Dr. Hema Divakar ma'am, for taking her valuable time for coming for this event. Dr. Abharani Sinha ma'am, thank you for accepting our invite and giving such a wonderful talk. And obviously, Dr. Mitra Saxena ma'am, thank you for moderating the panel so wonderfully. And obviously, I have to thank all the panelists, Poonam Khera ma'am, Prema ma'am, Tejavati ma'am, Neelam ma'am, Sunil Shah sir. And unfortunately, our two other panelists, Meera ma'am and Madhulumma ma'am, couldn't join due to some personal emergencies. So thank you everyone for being a part of this wonderful program. And also, I would like to thank our educational partners, Torrent Pharma, for helping us organize this entire O2S webinar series. We will now see everyone again on the 3rd of March, which is going to be our next program. So look forward for the WhatsApp messages, which will be coming on the groups and the emails to keep in touch with the next program. Thank you so much.
Sure. Thank you.
Thank you. Thank you so much.
Torrent would like to have the last word.
Yes, sir. Mr. Sunil Tiwari is there. He would like to say a few words.
Hello, everyone. We are now in the last section of the live O2 us masterclass. It was exciting and knowledge sharing. I'm sure you all must have learned some new things. Also, the chance to interact with the expert in field of gynecology through a QA session. On behalf of the entire Torrent, I would like to thank our chief guest, Dr. Hema Divakar, as well as eminent speaker Dr. Jaideep Tank and Abharadi Sinha. As well as thanks to our moderator Dr. Mita Saxena and Rohan Pasalkar, as well as senior co-convener Dr. Parikshit Tank. I would like to thanks our panelists also. That is Dr. Poonam Khera and Dr. Prema, Dr. Tejavati, Dr. Meera Laktakia, Dr. Neelam Mishra, Dr. Madhu Lumba, and Dr. Sunil Sa, who have given us time from their busy schedule. This program would have been incomplete without your experience and knowledge. Our special thank